Good morning. Thank you very much for the kind invitation for this international hands-on laboratory management activities. And I'll go straight to my topic, which is how safe is to freeze. Let me introduce myself. I'm head of embryology for Next Clinics International, and I'm also director of IVF laboratory in Next Fertility Ginepro, Bologna. I was also founder and shareholder of Anterializer, which is a company involved in developing technology for gas sterilization. And I was also a consultant for companies in IVF sector. So the topics of my presentation will be safety of cryopreservation. We will analyze together results and KPIs. What could be done to improve safety? And what could be done to optimize results and streamline the workflow? Let's consider safety of cryopreservation. We know that nowadays human gamete and embryo cryopreservation is integral to assisted reproductive techniques because optimizes treatment management and results. We know that cryopreserved cells can be stored for years, but also transported between authorized assisted reproductive centers. Of course, we need to set up appropriate procedure finalized to minimize physical shocks and contamination. How to evaluate our cryo program? We need to use performance indicators for cryobiology. What are KPIs? These are essential for evaluating the introduction of a technique or process. KPIs used in gamete and embryo cryopreservation relate to cryosurvival. They are typically assessed immediately post-thawing or warming and being evaluated through the return of apparently normal function or morphological development. All the embryologists have perception of how well reproductive cells and tissues should cryosurvive, but cryo KPIs require precise definitions and objective standardized methods for their determination. For example, in the case of oocytes, the proportion of oocytes intact post-cryopreservation, the capability of these oocytes to fertilize, cleave, and blastulate after injection, and then also clinical KPIs, such as pregnancy, implantation, and miscarriages rate. Let's start from the male gametes and what can say about cryopreservation of spermatozoa. We know that it is simple because spermatozoa are cells with low content of water. So we have a favorable nucleus-cytoplasm ratio. Reduced water means high resistance to freezing and thawing procedures. We know that cryopreserved spermatozoa perform as well as their fresh counterparts, also after long-term cryostorage, 20, 30 years. What is very relevant is that we need to use cryoprotectant because, just to give you an example, forced DNA damage is caused by the direct immersion of spermatozoa in liquid nitrogen without cryoprotectant. So what is very important is to follow the protocols that we have to cryopreserved spermatozoa, which is to mix the seminal plasma and spermatozoa with cryopreservant that can be yolk buffer and other well-known cryoprotectant that are used for many, many years in our field. Let's consider the female gamete, which is totally different. We know that outside cryo preservation is tricky, difficult, but now we know that long-term cryo storage of cryo preserved oocyte is possible. We can say that this technique is consistent, effective, and safe because we have reports regarding safety of baby born from frozen vitrified oocytes. It is possible to have high survival rate. And now we are using the technique called vitrification. We will go deeper in the details about vitrification, and we know that it is possible to have 90% of survival rate, which is very, very, very high. And we know that frozen oocytes perform as well as the fresh counterparts. This allowed us to uh, um, use these oocytes for egg donation program, just to give you an example, or also use this technique for fertility preservation for young women or for cancer patients. Uh, Embryo cryopreservation, particularly blastocysts, are very resistant, much more than the oocyte. This is because the nucleus cytoplasm ratio is more favorable than oocytes. Oocytes are rich in cytoplasm and rich in water. This means very high sensitivity to cryo-injury. With blastocysts, we have better situation. Also for blastocysts, we have the confirmation from many studies that long-term cryo storage it is possible. This technique is consistent. Many groups obtained results. Is effective, safe. We have information about safety and baby bones from vitrified blastocysts and embryos. The survival rate is amazing because we can nowadays, we will analyze this, say that the gold standard, the benchmark is 99% with vitrification, which is the highest KPI that we can find in IVF. So we don't have 99% in oocyte retrieval, ICSI, fertilization, embryo cleavage. 99% is just for embryo survival rate, which is so nearly 100%. We know that frozen embryos perform as well as the fresh counterparts, and in fact, nowadays it is very used to delay the embryo transfer by using the freeze-all technique, particularly because this helps us to make the embryo transfer in a more favorable situation when the uterus is ready, really ready to receive the embryo. And most of all, because we can also perform genetic tests on the embryos. So we perform a biopsy, we freeze the embryos, we purify the embryos, and then we have time to analyze the cells from trophoectoderm and have the information regarding the karyotype of these embryos. This technique called PGTA is helping us to optimize the results. As we said, we are using now the vitrification. We know that ice crystals have detrimental effect. That's the reason why I told you that oocyte vitrification is very tricky because we have a large amount of water in the cytoplasm. But the fact that the ice crystals are dangerous was known since the beginning of cryobiology. Also, Father Luyer in 1937, 1940, was aware about the risk of ice crystals. So we need to avoid these ice crystals during vitrification and warming. Go back to this slide. It is very important to understand that any material can vitrify, and this is directly dependent on the viscosity of the material, the cooling rate we are using, and the volume of the sample. This is the formula vitrification from Yavin and Arab. To increase viscosity, we use cryoprotectant that can be intracellular, that going it is permeating in the cell membrane, and extracellular, which are macromolecules that are draining out the water and increasing also the viscosity inside the cell. For many years, we used the slow freezing. To be honest, the final goal is to obtain the glassy state in the cytoplasm. Okay, the difference is that with vitrification we obtain the glassy state by using very viscous medium and very high cooling rate, as we have seen on the Yabin-Hara formula, plunging the cells directly in the liquid nitrogen. So when we talk about vitrification, we talk about the vitrification through direct immersion in liquid nitrogen. In the past, we were more prone to use a protocol with slow freezing by using programmable freezer that allow us to obtain the glassy state inside the cell by in the moment in which the cryoprotectant, the water in the holding solution iced, and the cryoprotectant was in high concentration were around the cell, around the cytoplasm in the moment of the seeding, which is the moment in which there is the phase change between liquid and solid of the cytoplasm. So at the very end, we can say that slow freezing is comparable to vitrification. So it is an intracellular vitrification with ice in the extracellular compartment. This has some advantages, such as the more stability of the inside the straw to temperature shocks, but the efficiency of vitrification through direct immersion in liquid nitrogen is terrific. In fact, if we consider not many years ago, this is 2012, and these are the key performance indicator for cryopreservation of alpha, which is the International Society of Embryology. Look at the benchmark, not the competence, the benchmark we aim to in not more than 10 years ago for slow freezing was 55%. This means that in a ideal slow freezing setup, the maximum survival rate expected was 55%. And then look, after just 5 years, this is the KPI, the benchmark for the KPI of blastocyst survival rate. It is 99%. So this means that in 5 years, we changed totally our perspective of survival for our cell. For the embryos now, after just 5 years, the same scientific societies is setting now that the benchmark value of 99% and the competency value of a vitrification program in 90%, okay, which is 40 points more than the benchmark value with slow freezing 5 years before. So what we can say, which is the impact of vitrification by direct immersion liquid nitrogen in IVF is terrific. Now it is a gold standard for at least 10 years. Vitrification made it possible to efficiently freeze oocytes. We have seen 90% of survival. facilitate the movement of frozen cells instead of patients. And this is very relevant, reducing reproductive tourism, receive oocyte and embryos for transnational egg donation program. Well, what it is impressive is double the embryo survival rate at towing. If we consider that about 3 million babies worldwide have been born from crab-shaped embryos, it can be estimated that nearly 1 million babies would not have been born if we had stayed with slow freezing. I would like to let you this reflection. Just considering in Italy, the situation among babies born from IVF, more than 1 in 2 babies comes from vitrified cells. 60% is the percentage of babies born from vitrified oocyte or embryo. So, of course, there are concerns in any technique we introduce in IVF. As we say, there is a higher tendency toward cryopreserving embryos. This because we have seen the terrific survival rate. It's impressive. We can say that there is still lack of knowledge about which is the more convenient time point for embryo cryopreservation, considering health consequences in the future. We know that blastocyst survival is amazing. So that the morphological embryo assessment is the most common criteria up to date, but we should be able in the future also to consider the epigenetic criterion that could potentially complement future decisions concerning a safer prognosis in terms of impact. So we are still looking to the application of novel technologies in research that help us to have more information regarding ART in general and embryo frozen embryo transfer. So we can say that this is what this it emerged from studies that there is an association between ART conceived babies and risk of congenital birth defects and low birth weight. In the case of frozen embryo transfer, some authors observed a higher birth weight compared with fresh replacement. We cannot say it is vitrification responsible for the higher birth weight offspring, or other factors. So some authors hypothesize the use of cryoprotectant or the drug used for endometrial preparation, so not vitrification itself, but the procedure to preparing the endometrium to receive the embryo. Overall, the epigenome establishment in cryopreserved embryos oocyte remains still to be fully clarified. And this will be very relevant in the future also for egg donation programs, to understand how epigenetic of the recipient mother can influence the genetic the embryo growing in the recipient. So the number of reports available on the topic is currently limited, and this lack of information needs to be clarified. We all agree about this. And probably we need advancement in molecular technology to have more information about epigenetics and about the potential risk of cryoprotectants. This is what many authors are asking, but I would like to comment this because as we say that many authors and reviewers are saying the growing trend of human oocytes cryopreservation is evident, commenting that in some case there is a lower birth rate in cycles compared to fresh cycles in egg donation. Despite this, no increase in aneuploidy rate has been reported for cryocycles. The fear still after 10 years, despite the fact that I showed you, which is the difference between vitrification and slow freezing, but there are still authors, probably they are not very into vitrification, saying, oh, there is a high percentage of cryoprotectant in the vitrification solution, which is 15% DMSO. We know DMSO can be toxic, teratogenic for the cell. So this may influence gene expression, disruption of epigenetic markers. I just would like to point out this, which is very relevant. Probably many authors are not informed that the intracellular cryoprotectant concentration after vitrification is lower. It's much more lower than after slow freezing. And this was elegantly demonstrated by Pierre van der Zwarmen in 2013. So what we done in the last 10 years is to reducing the exposure of the cell, or the DNA of this cell, to potentially toxic cryoprotectant. And this must be clarified because often these review articles are published in the journal without the proper revision of embryologists expert in cryobiology. Again, regarding, for example, some meta-analysis which observed that the prolonged storage time of vitrified embryos may negatively affect pregnancy outcomes, including pregnancy rate, clinical pregnancy. This was a study by a Chinese group which analyzed their results. And by analyzing well this article, so I remember that when this article was published, were concerned again about the risk of cryopreservation, but analyzing well this study, we observed, me together with Gabor Vado, which is who is one of the godfather of vitrification, that we observed the survival rate in this study, which is the most important KPI for cryo, as I said before, is comparable between the study group. So in this case, they studied embryos which were cryostored for some months and years. Okay. But what we observed that the progressive decrease of pregnancy and implantation rate was not related to cryostorage, not study, but it was related to patient age, because there was a very important bias on patient age, basic characteristics of the patient, and also cryostorage conditions, because they weren't able to demonstrate that the cryostorage condition were uniform during all the period of the study. Again, another wake-up call was this article published on a very relevant journal, very important journal, such as top journals such as JAMA. And this Danish group declared that the use of frozen embryo transfer was associated with a small increase of risk of childhood cancer compared with children born to fertile women. They analyzed the data set in the North Europe, and again, these authors were not expert in cryopreservation, because during the period of this study, which was 1996, 2012, the majority of the embryos were cryopreserved by the traditional slow freezing. As we said before, the slow freezing exposed the embryos to a high concentration, very high concentration of cryoprotectant. And then, even 2012, an estimated 50% of embryos were still slowly frozen. But as I said before, since 2005, vitrification has been preferred, and currently more than 95% of embryos, probably now 100% of embryos, are cryopreserved by vitrification. Vitrification attempts to eliminate ice formation both in an extracellular and intracellular solutions, as I described before in my previous slides. To achieve this goal, vitrification differs from slow-rate freezing in almost all respects, including the composition of cryoprotectants, concentration of cryoprotectants, equilibration times, temperatures, volumes, cooling rates, and rehydration after warming. So, the authors hypothesized that the increased incidence of this cancer could be related to DNA damage during cryopreservation, because they read that cryoprotectants are dangerous for DNA, but they are not expert in vitrification, because ice formation during slow rate freezing may contribute to this. And also the exposure or cryoprotectant exposure during slow freezing might contribute to this, but not in vitrification. This is negligible in vitrification. The exposure to permeating cryoprotectant is negligible during vitrification. The potential toxic effect of cryoprotectant have proven unfounded, because the final intracellular concentration is lower with vitrification than with slow rate freezing. So I think we need to make a plea to all the embryologists and also to all the reader of these articles, because they need to understand, and they need to learn to compare apple with apple and pear with pear. Again, Sargisons on PLOS. Children born after embryo transfer, frozen embryo transfer, have high risk of childhood cancer. They use the same data set of Sargison increased with other numbers. And then they concluded that the finding raised concerns considering the increasing use of frozen embryo transfer, in particular the freeze-all strategies with a clear medical indication. And other reviewers and editors said, okay, probably freezing the embryo is dangerous again. This study was based on old data sets in which the embryo were cryo preserved with slow freezing. Did you remember what I showed before? At that time, survival rate was, the aim of survival rate was 55%. So we are talking about a technique which is not efficient. And so the same consideration we made with the other for the other study is can be done for this study. Okay, so far vitrification has been found superior for oocytes as well as embryos in mammalian species regarding morphological survival, developmental competence, and overall outcomes. The introduction of vitrification, as I showed before, was one of the most significant achievements in assisted reproductive techniques in the new century, both as a standalone procedure for different indications. This was the conclusion of our comment to all these kind of studies, me together with Gabor Weiter, to suggest drastic restriction on its use and warn the public about certain dangers based on evidence collected from a period where another cryopreservation procedure was predominantly applied, seems unjustified and may cause much more harm than good. So let's consider this when we talk about safety of vitrification. Okay, what we can do to improve safety. Let's consider other aspects related to the direct immersion of the cells in liquid nitrogen. We use liquid nitrogen because we know that liquid nitrogen, it is not toxic and is a key cryogenic agent in cooling and freezing for healthcare, but also food and beverage. But as we vitrify the embryos and oocytes, also contaminants can be vitrified. Contaminants were found inside cryobanks, in IVF cryobanks, were found viruses, bacteria, fungi, and contamination creates risks for biological samples and the patients and for quality. Just to give an example, in 1995, 6 patients were infected with ABV following transplantation of liquid nitrogen contaminated bone marrow and blood stem cells into a cryobank. So many applications require sterile liquid nitrogen. We can say that vitrification, warming, cryostorage probably need this precaution. And this is very important in the light that it has been analyzed that the waste of money due to contamination, but the contamination that we can see in the lab, it is approximately 100 million per year, $100 million per year, okay? But this is just the contamination that we can see. So when you go to eat the ice cream, where would you eat the ice cream? In a used box or in a new box? Why I'm asking this to you? I'll show you. Why? This box is still used for vitrification. These pictures was made in one of the largest lab in Europe. And in my last pilgrimage in all around the labs in Europe, I always make pictures of these boxes. And this is the boxes that every day in the labs it is used. So can you consider that it is possible to clean this? No. So the risk of, we use specific cryocarriers to plunge the cells into liquid nitrogen. The risk of contamination of the culture medium at warming through the contact between the cell and the outer surface of the open carrier cannot be excluded because we use these dirty boxes. We have no information regarding the liquid nitrogen we are using. So this risk is omnipresent. The possibility of contamination is just related to adhesion of these frozen microorganisms in the carrier. So they are not infecting because they are frozen, they are vitrified. So then when we plunge these cells, the carrier in the wells for warming, we are bringing with us the contaminants and these may reactivate at 37 degrees. So this is the risk, which is very small, it's little, but it is omnipresent if we are not certifying the sterility of all the material we are using, including liquid nitrogen and boxes. So even with closed system are the carriers which were developed years ago, in which the cells are put in a carrier and then enclosed in a wrapping and then plunged in the liquid nitrogen. This is reducing the speed of cooling, so this is not preferred for vitrification in many situations. But the real risk is not open or closed carrier. The real risk is this box of 1 liter of liquid nitrogen that we bring in our worktops for countless procedures. We are performing something like 20 between vitrification and warming procedures per day, every day. And we have everything control regarding contamination. We wear gloves, masks, we use single-use carriers, but we use always the same box, which is dirty. And the liquid nitrogen, we have no information regarding the contaminants in the liquid nitrogen. So considering that we are making many handlings between centers, also because thanks to vitrification now, it's very easy to have high survival rates and also So it's transportation between different countries. But let's consider when we perform a transportation, we have various steps in which we are using our carriers in boxes, in dirty boxes and liquid nitrogen in which we have no control. And then we transport in transport dewars and we expose this liquid nitrogen to potential contamination because we know very well we cannot close hermetically the liquid nitrogen. So we had the experience of COVID in which in some cases, some goods, also food goods, were blocked to China, just to give an example, from Brazil to China, from Northern Europe to China, because it was found the COVID in the boxes. So can you understand which is the risk? It is not just COVID. Any contaminant in the future can be a time bomb. We know now that it was revived, a virus that was in the permafrost in Siberia, which had 40,000 years. It was frozen for 40,000 years. So just in a small scale, considering that what we have in our crab banks can be revived when using a dirty liquid nitrogen and a dirty box. So it is possible to sterilize the liquid nitrogen. It can be used the liquid nitrogen. My group had this experience, and to kill viruses, prions, the smallest microorganism which are not filtered by filters. UV, it is very, very efficient, and we need a small amount of radiation to kill this virus. But what is very interesting is that we can use sterile, clean liquid nitrogen to wash the carriers every time we take out the carriers from the tank. This means that we are doing this additional washing and minimizing the risk of contamination. Just to give you an example, in this study, we performed this study in 2012, and we performed the fourth contamination of liquid nitrogen, which was 10,000 times higher, the contamination even found in the IVF cryo tanks. So this means a very high titer of contaminants. And what we did, we plunged the carriers into this contaminated liquid nitrogen. Part of these carriers were analyzed for microbial growth, and 100% of these carriers showed microbial growth, but another part of these carriers were washed with clean sterile liquid nitrogen, and this showed no microbial growth, which was zero. So this additional washing just before warming, it is sufficient to minimize and take to zero the potential contamination coming from our cryo tanks. So now after the COVID, the many authors suggested to implement a good manufacturing practice in ART, including the use of single personalized disposable vitrification containers, to sterilize the liquid nitrogen before use, to wash cryopreserved specimens with sterile liquid nitrogen before thawing and warming. So what I showed in our study 10 years ago, more than 10 years ago. Also authors that thought 10 years ago that the risk of cross-contamination through liquid nitrogen was negligible, such as Kimball Pomeroy. It is nowadays suggesting to sterilize the liquid nitrogen. But even the WHO is suggesting to sterilize the liquid nitrogen and to decontaminate the cryopreserved specimens with a washing before warming. So we are entering in a new era in which probably after this pandemic, we need to take care about the contamination coming from the liquid nitrogen, but also to perform a single personalized virus-free vitrification. How we can do it? Suggesting is to use also systems that is reassuring us about the putting in safety data and also to safety in tracking medical and laboratory procedures such as blockchain. So this is what we have done in our lab, and there is a technology now that allows us to perform personalized virus-free blockchain vitrification, just using a single-use container, pre-sterilized with sterile liquid nitrogen, sterilized with UV. The box is sterilized, and then this is the success that we obtained during the pandemic. More than 500 babies are born with this blockchain virus-free technology. And this technology is spreading all around Europe. There are installations of this device in Germany and China, Italy, of course, Spain. So if they were informed, which box would our patient prefer? This one or this one? Probably they will go to the single-use box. Okay, so last topic of this presentation, of this lesson, is what could be done to optimize results and streamline the workflow. So we said that prep cells are transported between authorized assisted reproductive centers and oocytes and embryos. During these years were vitrified using different brands of ready-to-use kits. This was depending on the availability on the market. In some countries, some received certification, some other no. In some cases, we were not ready to have ready-to-use kits. We were making in-house kits. And now we have these embryos or oocytes cryopreserved. Just yesterday, I received from England a request from a big group, a big chain of clinics asking information on how to warm oocytes that were frozen with a given protocol. So what we have done in 2014, we started to think that probably it could be useful to have a universal protocol to warm any cell, irrespective of the kits used for vitrification, but also the protocol, slow freezing, vitrification. You know, we talked about slow freezing and vitrification. And as we say that slow freezing is just vitrification with the ice layers outside, the cytoplasm is vitrified. So probably using the same protocol of vitrification, or warming the vitrified cell, could be used also for slow frozen. And what we did, we performed this study on oocytes, which, as I said before, these are the most sensitive cells for cryo-injury. And we divided these oocytes, which were donated for research, in two groups. One was the warmed with rapid warming used for vitrification. The other one was warmed with the conventional thawing for slow frozen cells. And what we observed, that amazing survival, the development competence was comparable. So this means that we demonstrated for the first time that it was possible to use the warming protocol to warm also cells which were slow frozen. So we hypothesized the ideal procedure, universal procedure to warm any reproductive cell, and why not tissue? Let's consider that many ovarian samples are slow frozen, and nowadays all the thawing media for slow frozen cell and tissue are withdrawn from the market because are not used anymore. As we said, 100% of the embryos oocytes are frozen with vitrification. So we need to give an answer also to this cancer patient, give a future to them. Because we know that we need to use approved kits, approved warming medium for human use, okay? So the idea is this, to use the warming protocol to warm any cell irrespective of the freezing protocol. In these last years, we tested this idea with different basic medium in the warming kits. So with TC under 99, which is content, which is in the some kits such as Kit, Zato, Cryosec, but also HTF mob, so we can find it in Irvine, I guess, probably Sage, PBS, HAMS, because in the years we also made a in-house solution with PBS and HAMS. Any extracellular cryoprotectant, we know that mainly we use two extracellular cryoprotectant in vitrification solution, two macromolecules that can be sucrose or trehalose. Any kind of supplements, such as synthetic, such as hydroxypropyl cellulose, or also dextrans serum supplement, albumin, human albumin, etc. So what we kept fixed was the volume of the first solution in with the 1 molar of extracellular cryoprotectant. So 4 milliliters in 1 minute in 4 milliliters at 37 degrees to create the temperature delta from minus 196 to 37 degrees, large volume to be universal for any kind of carrier, because in some cases, if the strip of the carrier is large, probably you need more volume. I know that probably there are embryologists listening this lesson saying, oh, I have excellent results with the 1 milliliters of 1 molar solution, 500 microliters. Okay, I understand you. You got your setup in the lab, but usually use large volume help us to avoid fluctuation in temperature, such as also the washing in 0.5 and then in the washing solution. We suggest to use 300 microliters in wells, also in this case, to keep stable the solution and to reduce osmolarity changes. That's it. That's it. This is the conventional warming procedure for many, suggested for many cases. You can say yes, of course, but our duty in these years was to demonstrate that it was possible to combine different procedures and different kits, particularly different vitrification kits. And we show you what we had done. This was the first study published in 2017 in which we compared blastocysts. This was a very strict study, prospective randomized register study, in which we vitrified the blastocysts with chitozato and then warmed with sage, or warmed with chitozato, or vitrified with sage and warmed with chitozato, or vitrified with sage and warmed with sage. So 4 groups, different combination of the ready-to-use kits available on the market, and look, survival rate was comparable. So probably now for you can be normal, this situation, but at that time, manufacturers were saying that to not break the chain of loyalty to a kit. Again, this study was performed in the same period on more than 1,000 cleavage stage embryos, and we introduced also an in-house kit, and we combined in different combination the kits. Again, survival rate was comparable. In this way, we confirmed that it was possible to combine in different way these kits. Then we started to test this protocol on oocytes. In this case, more than 800 oocytes were vitrified with chitozato and then warmed with chitozato or Irvine kits. Look, survival rate was comparable, fertilization rate was comparable, blastulation rate comparable, and also implantation rates. So also on oocytes, we demonstrated that it was possible to combine different kits. So we said, okay, probably this is working in our hands. Let's involve another group. So we did this transnational study with 3 groups with different history. This study was performed in almost 2,000 oocytes, vitrified with chitozato, and then warmed, transported in Italy, and then warmed in Italy in 2 different centers. These were assigned to 2 groups for warming, again, like the previous study, with chitozato or with Irvine. The oocytes were all vitrified with chitozato. And again, survival, blastulation, implantation, live birth rates were all comparable, demonstrating that also in other hands, this protocol was efficient. And now I'm very happy that there are different groups that are making the coming out of this off-label use of warming kit brands. I think this is very relevant because probably you are already performing this in your lab, but the literature that we are producing now support the off-label use of different combination of vitrification and warming kits, allowing us to come out of the closet, making possible to choose our preferred kit based on reliability of distributor, price, availability in that country. I think this is very relevant to break the chain of the slavery to be linked just to a given brand. Okay, so we finally concluded this lesson. We talked about the safety of crop preservation. We talked about the terrific efficiency of vitrification. We can consider that nowadays on 3 million of babies born from cryopreserved cells, 1 million are born from vitrified cells. Of course, we need to keep the eye open regarding safety of these techniques, but please keep in mind that many studies were now made on data sets of baby born with slow freezing. And with slow freezing, the efficiency was lower, halved than vitrification, particularly on embryos. Cryoprotectant concentration inside the cells was higher. So we are talking about a totally different technique. We need to put this in clear, okay? We also analyze what we can do to improve safety, particularly related with countless procedures that we are performing in the same boxes, which are duty boxes. I think, and these boxes are not medical device, so just to improve and change our habits, track what we are doing in the lab during vitrification. Last but not least, I think very, very relevant, it is how to streamline the workflow in our lab when we are warming the cells by using a single protocol with ready-to-use kits, with any ready-to-use kit in the market that has 1 molar and 0.0 molar sucrose. And then we know that also technology is improving. There are some groups that are also making these steps shorter. And I think this is possible because we made that study on universal protocols. So any improvement, any changes in the warming and maybe an ultra warming that we are facing in these days, we are reading publication these days, are coming from the courage of the first embryologists that declared this off-label use of warming kits. Thank you for your attention. It was marvelous for me giving this lecture. Thank you.